So my name is Jerome Avouac. I'm a professor of rheumatology in Paris, France, in Cochin Hospital. And we performed a work on the outcome of COVID-19 in patients with inflammatory diseases treated with rituximab in France. So it's a collaborative work from a lot of centers in France. And the data are coming from the French and the COVID-19 cohort. So here are my disclosures. So preliminary reassuring data have been published on the risk of severe COVID-19 pneumonia in patients treated with rituximab for inflammatory rheumatic diseases. But on the other hand, observations of severe forms of COVID-19 have been published in patients with IRMD receiving rituximab. And in the French RMD COVID-19 cohort, we observed the potential risk of more severe COVID-19 in patients treated with rituximab. So the question is this a direct effect of the drug, or is it related to other confounding factors? To that end, we performed this study to investigate whether treatment with rituximab is associated with COVID-19 related severe infection and death. So here's the methods. So we use the observational, the French RMD COVID-19 cohort, which is it was an observational study. And the primary endpoint of the study was to show the severity rate of COVID-19 in rituximab treated patients. And severe disease was defined by hospitalization in intensive care unit or death. And the secondary objectives were to analyze the death rate and length of hospital stay. And we used two different control groups for comparison with rituximab treated patients. The first group, of all non-rituximab treated patients, and a second group, and I think in my opinion is very interesting, is a group of rituximab untreated patients, but with diseases for which rituximab is a recognized therapeutic option. And we adjusted on the potential confounding factors using a propensity score method. So here is the characteristic of the population. So patients treated with rituximab were significantly older than the overall patients on the non-rituximab group. And when you consider the patients not treated with rituximab but eligible for the drug, the age was similar. Regarding comorbidities, the frequency of comorbidities were also more frequent in patients with rituximab, especially cardiorespiratory disease, especially interstitial lung disease. And on this slide, you observe that the number of patients with at least comorbidity was higher in rituximab patients and similar to patients not treated with rituximab but eligible for this therapy. And the main diseases treated with rituximab was rheumatoid arthritis and also some connective tissue disorders like systemic sclerosis, lupus, or vasculitis. And you have here the frequency of the different treatments received by patients, and the frequency of corticosteroids was also higher in patients receiving rituximab compared to the other group of patients. And you have also the frequency of other targeted biologic therapies that patients in the non-rituximab group received, especially TNF-alpha inhibitors. So here is the results. Here are the results for the primary outcome, which was COVID-19 severity. The frequency of severe COVID-19 was 12.6% in our cohort. And as you can observe, the number of severe patients were numerically higher in the rituximab compared to the non-rituximab group. And after adjusting on the potential confounding factors, which are mentioned on the bottom of the slide, we observed that rituximab was associated with a more severe disease with an effect size of 3.26 and a p-value less than 0.001. And regarding the primary outcome of COVID-19 severity, when we compare with the population eligible for rituximab, the results were similar. The frequency of severe COVID-19 was 16.7%, and severe disease, as you see here, was also associated with treatment with rituximab with an effect size of 2.62. Regarding the secondary outcomes, death and hospital stay, the frequency of death in our cohort was 8.16%, And the number of deaths was numerically higher in patients receiving rituximab compared to the non-rituximab group, with 20.6% versus 7.4%. But after adjusting for all confounding factors, the risk of death was not significantly associated with the treatment with rituximab, with an effect size of 1.32 and a non-significant p-value of 0.53. And regarding, the previous slide, the length of hospital stay was significantly higher also in patients receiving rituximab compared to the non-rituximab group. The results were similar when we compared rituximab patients to the population eligible for rituximab but not receiving this therapy. The number of deaths was higher in patients receiving rituximab compared to the control group, and the frequency was close to 21% versus 10%. But after adjustment of the confounding factors, the association with death was non-significant, with an effect size of 1.48 and a p-value non-significant of 0.32. And length of hospital stay was significantly longer in patients receiving rituximab compared to the non-rituximab group. Very interestingly, we also looked to the interval between the last infusion of rituximab and the first symptoms of COVID-19. And the shorter was the time between the last infusion and the first symptom, the more severe was the disease. And also the frequency of death was significantly increased in the case of the duration between the last infusion of rituximab and the first COVID-19 symptoms was short. So to conclude, rituximab therapy was associated with a more severe risk of COVID-19 infection. And death rate was numerically higher in rituximab-treated patients, but after adjusting on potential confounding factors, this risk was not related directly to rituximab, but more probably related to associated factors. And rituximab will have to be applied with particular caution in patients with high RMDs, especially if they suffer from other comorbidities. And of course, I would like to thank all our French consortium, FA2R, SFR, SNFMI, Sofreni, CRI, and Immediate, who helped a lot to perform this study, and Elodie Dremez and Eugène Labroche for their statistical analysis, and all contributors, and the Sanoya for the ECRF design. Thank you very much for attention.